Hi, I'm Noel Armstrong. I'm a podiatrist here at the Foot and Ankle Center at Valley View. Had a chance to look over some of Brian's slides before this lecture, and I'm really looking forward to it.
And I'm Brian Burkhardt. I'm a physical therapist here in Glenwood Springs in the rehab department. And tonight we'll be giving a talk on strengthening for the lower legs.
We have a few housekeeping items to address before we get started. You can submit questions through the Q&A chat at the bottom of your screen. Your question could be answered live at the end of the presentation. We will try our best to answer your questions. We are unable to answer questions regarding personal health information. And now we will get started.
All right. Well, thanks for joining us this evening, and thanks to Valley View University for giving us this platform to share some of our knowledge with the general public. As the title suggests, we're going to be talking about strengthening for the lower legs this evening. And I added this subtitle in an introduction on how this ties into resilience, performance, and longevity, as there's a lot of connections with these other areas, as well as lower leg strengthening. As Haley just said, a quick disclaimer, this presentation offers general evidence-based information, not tailored to individual medical conditions. Consulting a healthcare professional is advised for specific issues and strongly recommended when beginning any new exercise or program. All right, just a quick outline. So to start, I'll go over an introduction and kind of explain some of my rationale for tying in longevity into lower leg strength. And we'll go into the specific anatomy, function, and pathologies that are common in the lower leg. Tonight, I'll be primarily focusing on tendons because I feel like they are quite common, but also an area that is often misunderstood. And then we'll go into how you can build strong, resilient tendons. And then finally, provide some information on indicators when you might want to seek professional help. All right, so what brings us all here tonight? Well, based on what I've heard after nearly a decade as a PT, it's longevity, doing the activities we love as long as possible. But pain, injury, debility can prevent this, and a lot of the most common causes are below the knee. And while there are several links between longevity of life and lower leg strength, including things such as gait or walking speed, which is a predictor for all-cause mortality. The reason I make this connection is because what the research tells us is the best types of exercise for building strength in our muscles, tendons, and bones, especially in the lower leg, is very similar to the same types of exercise that are being shown in the research to be the best for improving longevity and health span. So I would imagine most of the general population understands the importance of exercise with respect to our health at this point. In fact, there was a study that came out in 2024 that showed exercise as the strongest predictor of all-cause mortality, period, meaning it was actually a stronger predictor of lifespan than even age. However, what I see quite frequently is a lack of understanding of what types of exercise are best to achieve certain goals. So whether you're trying to run faster, heal or prevent an injury, improve longevity, or anywhere in between, that's what our talk will focus on tonight. All right, so this figure is showing lifespan and health span essentially over the past 40 years. And you can see that the general trend is that they're both have been increasing. However, the increases in life expectancy have outpaced the improvements in health span, resulting in nearly 2 years of unhealthy years lived, which I think we can all agree is not a good thing. But I think that there's good evidence to support that exercise is uniquely positioned to help minimize this gap. So how is the best way to do this? So I was on a run recently with Dr. Ash Kabra, who works in the urology department here, and we were discussing our unique patient population here in the Roaring Fork Valley and how this is essentially a blue zone, so an area where people age exceptionally well. And in many cases, why we should be modifying our treatment approaches and, of course, always treating the individual. Because based on the goals that I often hear around here, they kind of look like this. They're not even on the scale of this chart. So we should not be treating people based on age and national averages, because if we are, we're really probably underdosing and underserving our community. But no matter where your goals fall on this spectrum, I think we need to be planning ahead and performing the right types, intensities, and doses of exercise in order to achieve these goals. Because if you're basing your exercise routine off of your neighbor or the internet, you're probably putting yourself at risk of injury by under or overloading. All right, so let's talk about the bad news. So I think we all understand somewhat the process of aging. And with respect to loss of strength, we refer to this process as sarcopenia. And you can see from this figure here that yes, it does begin around age 40. So we have peak muscle mass between 30 and 40 years old, but after that, we're actually losing 8% on average of our muscle mass per decade. And tendons would also kind of fall into this category, as we have a weakening of our tendons due to decreased collagen and blood flow. And you can see that without exercise, that this will put a lot of people below a disability threshold where people are losing functional independence shortly after sometimes the age of retirement. Okay, so now for the good news. So with exercise, we can actually decrease this decline and therefore extend health span, prevent disability, and loss of function and independence. And like I explained to a lot of middle-aged patients I see, including people in their 50s, 60s, 70s, if you're only doing the activities you hope to still be doing in your 80s and 90s, like walking and getting up from the floor, it's probably not enough, because no one's line here is horizontal. So what can you do to ensure you're challenging yourself enough now? In other words, what are the best types of exercise? All right, so I did want to share a little pearl, an anecdotal story, if you will. If those previous slides are making some of you feel a little anxious and worried, is it too late? You know, is it too late for me to get on track? I will say that I revisited this person who I've been fortunate enough to treat about a year ago, who is turning 100 years old later this year. And she has kept up with her exercise program over the last year. And when I first met this person, they had difficulty getting up out of bed, needed help standing up from a chair, and could not stand unsupported. And a few months later, I had her standing on balance pads and doing overhead presses with dumbbells, like shown in this figure. And with consistent daily exercise and the right type of exercise, she's now actually able to walk even short distances without a cane in some cases, and certainly get up from a chair multiple times. So I just wanted to share that to inspire some of you that if you're worried it's too late, I can assure you that it's probably not. But I will say that I think that people are a lot capable of lifting heavier and performing higher intensity types of exercises than they might believe. And a little spoiler alert, but these are the types of exercise that research supports is best for improving longevity, health span, and lower leg strength. All right, so to dive into the anatomy of the lower leg, I'm not going to get into too many details here, but when we're talking about the bones, we have the main weight-bearing bone, which includes the bottom half of our knee and the top half of our ankle. That's the tibia. The fibula is off to the side. And then I also pointed out here the calcaneus, or the heel bone. For time's sake, I'm not going to be diving into the ankle or foot at all in this talk. Okay, now to focus on more of the muscles and tendons, which will be more of the focus for this evening. So we have the calf muscles, the gastrocnemius, and the soleus, which merge to form the Achilles tendon. Beneath that, we have some long toe flexors, and then we have the tibialis posterior as well. The arrow here is pointing to the tendon, which I'll kind of lightly mention as we get into tendons in a little bit. And then we also have the peroneal muscles on the outside of the leg. All right, narrowing in on the Achilles tendon. So it is the longest and strongest tendon in the body. And it primarily functions as a spring for efficient energy storage and return. And it's also essential for protecting our muscles and joints with shock absorption. And like I said earlier, the reason I'm going to focus on tendons this evening is because they are some of the most common lower leg injuries and yet the most challenging to treat in a lot of cases because I think they are largely misunderstood. All right, another reason the calf muscles are in particular are very important, as this figure here shows that almost half of our forward propulsion with walking is going to come from the calf muscles. So that's kind of what this is showing here. So when we're talking about the fact that gait speed is a good predictor of all-cause mortality and longevity, I would say like this is a pretty good argument why having strong calf muscles would be also important. All right, so some common lower limb injuries. So the highest proportion of running injuries occur from the knee downwards, and two of the most common are listed here. And a lot of times these types of injuries are somewhat overuse, or from a rapid increase in activity. A good example of when I see some of these injuries is after surgery, maybe after someone's completed their rehab for a surgery and they're just building their activity back up, is a common time I see Achilles tendon type issues, as well as in the springtime or when someone's starting a new training program. But I do want to point out that that is not always the case in what contributes to these types of injuries. But it really does come down to repetitive loads that are exceeding the tissue capacity. So as far as the Achilles tendon, I do want to point out that there are several different types of Achilles tendon pain. And so it is best to consult with a healthcare professional because you would treat these types of injuries quite differently. So you do want a proper diagnosis. So in addition to Achilles tendonitis, which I'll get into in a second, there's Achilles peritendinitis, which is an inflammation of the sheath of the tendon, which is more from the friction. So you do want to treat that a little more conservatively, as well as insertional Achilles tendonitis, which is actually more of a compression. It's going to be right on the back of the heel bone. So things that you would want to avoid with that would be stretching, incline walking, heel drops, and shoes with a firm heel cup, anything that's going to create pressure in the back of the heel. Okay, and then as far as the Achilles tendinopathy, I do want to say that we in the clinic use the term Achilles tendinopathy because most of the time what we're actually seeing with this condition is that it's a chronic weakening of the tendon, not an acute inflammatory condition. So if you've had your symptoms for more than a week or two, it's probably falling into this more Achilles tendinopathy. And in most cases, we would also kind of consider plantar fasciitis really more of a fasciopathy as well. Okay, so another reason why there's so many lower leg injuries, especially with running, is as you can see here, when we're running, our body is going to see forces of 2.5 times our body weight, which is quite a bit. But if you look at where I circled, that the calf muscle, specifically the soleus and the Achilles tendon, are actually going to see 6 to 8 times the forces of our body weight. So while running is great at strengthening our engine, it's really not the best for strengthening our muscles, tendons, and bones. In physical therapy, we're always interested in getting to the root cause of someone's issue. And I just wanted to add a note here that sometimes that is how you're moving, how you're walking, how you're running. And here's a couple examples. Gait analysis is something that I'm passionate about. And you can see that on the left, the runner is really overstriding. Their foot's landing way in front of their body and they're landing on their toes. And on the right in the red, you can see this runner is kind of deflating where they're landing with a really flexed ankle and knee. And that's going to put a lot of tensile load on that Achilles tendon. So both of these cases would be examples of like how your running gait could contribute to this kind of injury, regardless of perhaps a loading progression. Something that I like to use in the clinic is this Run Easy belt, which is a sensor that you wear around your waist, and it has an accelerometer and different measuring metrics that take 1,000 data points per second. And it's going to essentially quantify your lower leg strength and plyometric capacity. So you can use it for running analysis as well as quantifying your ability to jump. So I like to use it a lot because it allows us to not only determine like where you're at and dosing that you have a proper level exercise, but also it helps us track your progress over time. And it also provides real-time data. So for people that I have running on the treadmill, it's nice because they can actually see their score change as we're making modifications to their gait. And here's just an example of a report that it will produce for someone's jumping metrics. Okay, so why are tendons so hard to treat? Well, they behave somewhat uniquely in that they have a warm-up period. So meaning that a lot of times people might have their symptoms first thing in the morning or when they start doing an activity, and then they kind of get better. However, symptoms are often delayed, sometimes up to 24 hours. So it can be hard to know if you've done too much until you've already done too much. So why is this and what do we do? And as you can see in the question here, like, should I rest, ice, or stretch? In short, the answer is no. And I'll explain why. Next slide. Okay. So this is taken directly from the physical therapy clinical practice guidelines that came out in 2024. And A-level evidence is the highest tier level of evidence, and there is only one thing in this tier, meaning that it has the most research support for Achilles tendinopathy, and that is heavy load strengthening. Previously, this has included things like eccentrics, where you're doing the exercise, really emphasizing the lowering part, the heel lowering or lengthening part. And really that's just because most people can do more load with that type of exercise, but we know now that load is load. The second tier evidence for this is to avoid complete rest. So if the problem is a weak tendon, we don't want to be making that tendon weaker. Okay, so how do we navigate this issue of a tendon that's been perhaps overworked and now not letting it completely rest? Well, we kind of go about this by allowing people up to a 3 or 4 out of 10 discomfort, which I know is a little subjective, but it gives us a proxy for how much load we can provide to the tendon, and people are still able to get back to their baseline, ideally a 0 or a 1, within 24 hours. So as long as you're not increasing your symptoms from day to day, that's usually a good way to measure that you're doing adequate load. Okay, and then the third tier level evidence from this guideline includes heel lifts, which is going to reduce the passive tension on the tendon. And I know there's been a lot of questions from previous talks about shoes and footwear, so I thought I'd include this as well, that different types of tennis shoes have a different amount of what we call heel drop, which really means heel to toe drop, so how high the heel is. And 10 to 12 millimeters is kind of on the high end, so something like this Brooks Adrenaline and the Brooks Ghost are going to be on the higher end here, so that would be something that you also might consider, because you can kind of be limited with how much heel lift you can put inside a shoe before your like heel starts sliding out and that type of thing. So what sounds like the opposite of this? Well, if it sounds like stretching, that's kind of because it is. So if we know that reducing passive tension on the tendon makes it better, then why would we be doing the opposite of that? And similarly with ice, like I mentioned, that because this is not an inflammatory type condition, and like I mentioned also earlier with respect to aging, that we're already getting decreased blood flow to a tendon, which tend to have a relatively low amount of blood flow, that we don't, again, want to be further reducing that amount of blood flow to a tissue we're trying to heal. All right, so what do we do and how do we strengthen tendons? Well, as a starting point, you can start with an isometric, meaning just doing a static hold, something for up to 30 seconds. So something like holding this position that this girl is performing. And you can see she has her full body weight with a loaded backpack, and she's performing a heel raise. And I would say that, you know, if she's not approaching that 3 or 4 out of 10, I'd probably have her do this on one leg. So how much load is appropriate? So I think that this is very key as far as people understanding like how much leg strength they should have in order to be doing the activities that they want to do. So for walking, people should be able to perform a single leg heel raise in order to truly walk normally and not be putting themselves at risk of some other type of injury. And by that, I mean full range of motion as well. So dropping your heel off the step and going all the way up. Hiking, you should be able to do that with weight. And for running, I use single leg hops as a proxy. So if someone can't perform multiple single leg hops, then I'd say they're probably not ready to be running. All right. So this is an exercise I see thrown around quite a bit, and I think it's pretty obvious from what I've already said that this is not enough load. So a 20-pound dumbbell on your knee is obviously going to be significantly less than your body weight. So you're probably wasting your time. All right. So this is taken from a talk by Claire Minshall on the Physio Network on strength and conditioning. And what she's looking at here is comparing two studies, and this is just for like really pure strengthening information. So both of these studies performed a leg press, and they performed the study over an 8-week period, and they both performed 4 sets of this exercise. So in a lot of ways, very similar. The only difference really was that the group on the left performed a load that was putting them at their 3 to 5 rep max, meaning that they were not able to do more than 3 to 5 repetitions, compared to the study on the right, where they were doing an 8 to 12 repetition maximum, meaning that they were not going to failure. It was a lighter weight where they weren't going to failure until 8 to 12 reps. And you can see at the bottom that when they looked at muscle hypertrophy or the changes in muscle growth, that it really wasn't even comparable. I mean, almost twice as much as a percentage in strength gains with the group that was doing a heavier load, 3 to 5 reps. And this is just a pretty standard graphic from Fleck and Kramer in 1987. And just again, pointing out that when we're talking about power, which I'm going to talk about in a second, and strength, that we really want to be doing like the heavier loads, but kind of in, again, that like less than 6 repetitions. Okay, so let's talk about muscle power. So a talk on lower leg strength would not be complete without discussing this. For higher level athletes and longevity, we need to be including a power component, which is a strength speed component into our training plan. So, and really that's the main difference, is that power includes speed. And as I mentioned earlier, with respect to the calf and the Achilles, that they're going to be the most important when it comes to speed, power with walking and running. Additionally, I thought I'd include this study that came out, systematic review and meta-analysis that came out a few years ago. And just straight from the first line of the abstract, that muscle power is a more critical determinant of physical functioning in older adults than muscle strength, period. So something like on the right, where we're showing this person performing a 30-second sit to stand, which is a test that we use quite a bit in the clinic, that you're standing up and sitting down or almost performing the squat as fast as you can. So something like this would be more power related. So without veering off topic too much, I did want to include this study that just came out last year in the discussion about longevity and more vigorous, higher intensity type exercise. And what this study essentially showed is that for every 1 minute of vigorous level activity, you need 4 to 10 times as much duration of activity of moderate level activity in order to match the health benefits when we're looking at, again, like all causes of mortality. And for light activity, it's 100 to 200 times the duration. So while I think that there is certainly a time and a place and a role of doing like lighter and moderate level exercise, that depending on what your goals are, that I think it's essential that you are also including, yes, shorter bouts, but that you are including some of these more vigorous types of exercise. So something that's heavier, faster, and more vigorous. Okay, so circling back to progressing power in the lower leg. So you could certainly start with something like a chair hop, where you're not just doing sit to stands, but you're actually performing a hop at the top. If you take the chair away, you're essentially doing a squat jump. Another exercise that I really like is doing a wall mountain climber. And I know I don't have the video here with this, but I do want to point out that ideally this is performed as a skipping motion where you're performing a quick switch between one foot and the other foot, but you do have the support of the wall. So I think it's an appropriate exercise for some moderate level people. And but you should be ideally trying to get a small flight phase with this. The other reason that I like it for runners as well is it really helps cue proper running form with a forward lean and good hip mobility. Okay, some higher level types of exercises that you could perform for improving tendon strength and performance. So these would be things like that would be really beneficial for any runners out there. Well, skipping, honestly, like, I mean, you can perform like any level of skipping. So I think that is a good one for a lot of people. But if you're looking to really improve your running performance and optimize things that you can do skips for height, as I mentioned earlier, single leg hops, especially doing lateral single leg hops, like in the middle here, is also a great one that you can perform. And then on the high end of plyometric performance is bounding. So we have a lot of great hills around here. And this is one of my favorites, is to do bounding up a hill, which is essentially doing strides, intentionally doing a low cadence, where you're really emphasizing the pushing off and the forward drive. And that's going to be really one of the best things. And with all of these here, I do want to add that ideally we're going for minimal ground contact time and maximum flight time. All right, so I know what some of you are thinking out there. Well, what about my joints? With all of this heavy loading and jumping around. Well, I did want to share some information with some of you that might be concerned or skeptical. And yeah, go ahead. There's several studies that I've listed here that show that per unit distance, that load does not really differ between running and walking. So if you're doing 10,000 steps a day, that can approach or equal loads of a 10-kilometer run, because you're taking more steps with walking over the distance. There's also this publication that the Journal of Orthopedic Sports Physical Therapy put out several years ago, showing that the incidence of knee and hip osteoarthritis in non-runners was 10.2%. And in recreational runners, that dropped to 3.5%. So unless you're an elite, highly competitive runner doing lots and lots of miles, you're probably actually benefiting your joints by doing some type of running. Okay, and I know there's a lot of skiers out there, so I thought that I would include this study as well, comparing walking, running, alpine, and cross-country skiing with respect to peak hip joint forces. And I just want to point out that they, in this study, did a 7.6-minute mile run, which, quite frankly, is pretty fast. That I think most people are probably not running that fast. So that 5.2 times body weight forces is, probably a bit lower than that actually for most people. And if you can look at alpine skiing, that, if you're sticking to the greens, yeah, it's 4.1, but I know most of you aren't. So, it can go up to 7.8 times your body weight as far as loads of the hip joint. And even cross-country skiing is surprisingly not that, much lower than a fairly fast running pace. So a lot of you maybe are putting forces through your joints that are more than you might realize. So again, I put this up here, including this, and then go ahead to the next slide. I include these, and I want to be very clear that, like, I am not saying that everyone should be running by any means. But what I am trying to get across is that doing some of these types of exercises, a few sets of a few reps, a few times a week, is probably safe for most people. So, and I want to be very clear on this slide that as far as I know, a lot of you are wondering, well, what about my replaced joints? So this is something that you absolutely have to discuss with your orthopedic surgeon ahead of time. But I did want to, again, mention that over the past 10 years that there has been somewhat of a shift with respect to this. And there was this systematic review that came out last year that I cited here. And with certain populations that, that went through a proper rehab, it generally showed that there were low complication rates with returning to running after even knee replacements. So again, not saying that everyone should be running by any means, but I think that a lot of people who maybe are fearful or afraid or worried about like the real or fake joints, that doing some hops out of your chair or doing some skips and things like that, for a lot of people is probably safer than a lot of people might realize. Okay, all of that being said, I hope I've made it clear that load and dose matter when it comes to strengthening the lower leg. And any type of exercise program that you want to try to start doing, that it's really dependent on your current tissue capacity, your current activity level, and what your goals are. And in most cases, should be guided by a medical professional or someone who specializes in strengthening. So when should you seek help from a medical professional? Well, if you are having symptoms and they've been sticking around for more than a couple weeks, I would certainly recommend getting an evaluation from a medical professional. If you're interested more in injury prevention and performance, physical therapy, as well as I would say a shout out to coaches and personal trainers. There's some great ones in our community here as well. But I think guidance from someone who has knowledge and specializes in these things is definitely advisable when it comes to strengthening the lower leg. Specifically here in physical therapy, we do have targeted interventions to help with symptom management. Like I mentioned earlier, performing gait analysis and that type of thing can be also very beneficial. And helping with exercise progressions and getting to the root cause of people's issues and helping people achieve their goals. And with that, I will let Dr. Armstrong chime in if he has any comments. Otherwise, we will take any questions.
No, thank you. That was great. Let's see what the questions are out there. Let me make one comment. There was talk about muscle strengthening and power building. And then there was the tendons, which may have had some pathology. And so there's a clear separation between the ways that a tendon is rehabbed and the way that we build power and so forth, right? And just my understanding of it, to summarize, would be that the tendon that needs to build capacity, eccentric, isometric, heavy, slow resistance,
Right,
are kind of the hallmarks of treatment. And load is what drives the healing. And then so all of the plyometric things that we were showing, I would be tempted to use those to try to build my tendon capacity. But would you say they're able to do that? Or only in a very healthy tendon would you be doing some of those?
right, correct, yes. Yeah, so the heavy slow load would be more part of like the rehab process. And then once someone's not having any symptoms anymore, and again, depending on someone's goals, that you'd want to be doing more of those plyometric type activities.
One more thing that I think about sometimes with longevity and health span, that slide was really sobering. They showed 12 years of longevity past your health span. Those are times where what? You can't take care of the ADLs, you don't enjoy any. I mean, that's discouraging. So yeah, this talk is very appropriate for preventing that. The thing that I like to distinguish between those flexibility and mobility. Do you work in?
Yes.
Because I think one of them is essential to health span, maybe more than the other. What are your thoughts on that?
Yeah, I mean, I think that people do have a lot of questions about mobility or flexibility, I guess. I would say that something that I do like to integrate a lot of times with these types of conditions is dry needling or massage and rolling. Because of the issue with tensile load and stretching, like I mentioned, I would say that I am a little more cautious when prescribing stretching. A lot of times I feel that if you can address knots and trigger points in the muscle, including with needling or massage, that a lot of times people's range of motion improves without stretching. So I always find that as to be like a safer initial approach personally. But there certainly are times when calf stretching is absolutely necessary. But again, like I think it takes like proper knowledge and assessment from a professional in order to kind of suss that out. And I would say that, like there is that stretching the calf, for example, is something that is in the research absolutely indicated for something like a plantar fasciopathy.
Sure. I find a lot of people when they're increasing their flexibility, they think they're also increasing their mobility, which I would think isn't necessarily a given. For mobility, the ability to use that flexibility through a full range of motion, you have to be doing that strength training we're talking about as
Right.
well.
Yes.
So,
Yeah, and the other thing I would say with that is that, the eccentric piece, right? That I would say another thing that I would go to before just passive stretching would be an eccentric, where I have someone maybe doing the heel drop, not an insertional Achilles, but with maybe a regular Achilles, where they're doing a heavy load, but they're engaging the muscle while they're lengthening it.
Right.
And again, I think that that can be a safer approach than just doing a static hold for 2 minutes.
yeah.
Okay.
What is a rule of thumb for running mileage when building so I cannot get an overuse injury?
Yeah, I think the general rule of thumb is to not increase mileage more than 10% per week. I would say another principle is that you have 1 week a month where you back your mileage off. So you might be building your mileage for 3 weeks out of the month, and then you have a fourth week where you back your mileage back down to have a week where you're essentially allowing your body to adapt and recover. So those would be probably the top two principles that I would suggest. If you're, yeah, but again, there's great running coaches around that I think would be advisable as well.
How do you diagnose tendon pain?
I guess like if someone's having pain, I mean, I think it's pretty obvious if they're having pain.
I wonder if they mean tendinopathy, because the pain should be fairly apparent.
Yeah.
You squeeze it and it hurts.
How
Yeah.
can the cause get diagnosed?
Yeah. Oh, the cause?
Yeah.
The cause of the pain. Well, that's a good question. And I would say, I did allude to like the load versus tissue capacity, and that's really what it comes down to. But I mean, there's or flunolones, like there's certain types of like medications, antibiotics, especially that weaken tendons. There's a lot of factors that can contribute to this. Like I mentioned, like not just like how you're walking or running, but or how much or how fast you're progressing. There are a lot of factors. So I'd say that is a question that's a little bit harder to address. But I would say that if you're going by the principles that I mentioned earlier about like a gradual progression, and you're also doing these not just running and gradually increasing your mileage, but you're also doing these heavy load type activities, whether that's strength and or plyometrics power, that you're at least optimizing your risk of having one of these injuries.
I think that's perfect. I mean, I just look at it, look, there's the load that you put the tendon through or the muscle, and then there's the capacity, what it can take. There are things that lower its capacity, so we look for those. What he's talking about, the fluoroquinolones. A study just came out this year that Ozempic and GLP-1s raised the rates of tendon injuries 50%. And I mean, that's an ongoing concern. We don't know exactly why yet, but it's sobering because so many patients and people,
Yeah.
they take the GLP-1s, they feel better, they're lighter, and so they really ramp up their activity and end up with a ruptured Achilles or a pec or something. So things can decrease the capacity of the tendon or the muscle unit. And then also, a lot of the time, it's just the load goes up too quickly too. So, yeah, that's interesting.
Is imaging used to narrow down whether the injury is skeletal or tendon related?
So I guess there's a few different diagnoses that come to mind, I guess, with that question. So something that I kind of threw up on the slide but didn't talk about was shin splints, or medial tibial stress syndrome. So the latest research shows that that's not actually on the bone stress injury spectrum. That it's more likely the soleus muscle, one of the calf muscles, pulling on the periosteum, or the connective tissue on the outside of the tibia bone. That's like where that pain and irritation comes from. As far as insertional Achilles tendon issues, you can get what's called a Haglund's deformity, where there's like a bone spur bump on the heel. I have one of those. and that can contribute to that condition. Maybe you can speak to the imaging with that.
So, yeah, imaging is important in a lot of cases. I mean, I'm not sure if I understood the question correctly. Can you repeat it? Is imaging used to diagnose whether it's bone or?
Bone or tendon related?
Yeah, I mean, I think it can come in handy for that for sure. Bone spurs, for example, in the cases of fasciitis, and in some other cases, bone spurs are really not what we're thinking generate the pain. They may be more of a result or a symptom of the pain because your body is responding to the fasciopathy, the enthesiopathy, what we call where a tendon or a fascia, heavy, dense connective tissue connects to the bone. That's where you usually form spurs. And the spurs don't generate the pain most of the time. So most of the time, the pain, if you want to put it this way, the irritation, the stress generates the spur. So there are times where it's appropriate. It's just there's so many possibilities and permutations that it's hard to answer in a general way.
Yeah, and another condition that I put up on the slide but didn't talk too much about was the posterior tibial tendon dysfunction. And I will say that I've seen some people who have like where the attachment to the navicular bone is questioned if that's a bone stress injury or not. And those can be very hard to diagnose with imaging as well. So that certainly would be an example of a situation where like the tendon bone is the tendon tugging on the bone, like it can be a little hard to suss that out sometimes.
Well, and he's talking about this area right here, and there can be what's called an accessory navicular bone. So an X-ray can reveal the fact that your navicular, that whole bone, never fused into one solid, very strong cohesive unit. You have a little piece of bone that's attached poorly, so that gives the tendon less mechanical advantage and stuff. So yeah, there's so many possible X-ray findings in different areas and so forth. So when in doubt and we can't figure out what's going on in X-ray, certainly part of the workup. Let's put it that way.
What are your thoughts on weighted vests when walking or running?
So personally, I've been training for the Power 4 this winter, and with the lack of snow conditions that we had this year, I was wearing a heavy backpack and doing the stair climber at the gym a lot. So I will say that, you know, again, like it's going to come down to like what your goals are. Like I would say like that is going to be a great way to build like, for example, your hip strength. So I would say as far as like proving your hip strength for longevity, I think like that's a great idea, but I would also kind of dose it as somewhat of a strength exercise, and not that like you always need to be walking with a weighted vest or a backpack or something like that. Certainly if you're building up to a backpacking trip or something like that, I think you would want to obviously like do some gradual progression in training with that. As far as like running, I mean, other than just like carrying your water or whatever that you would need while you're running, I'm not sure that I would recommend a weighted vest just because I think that doing like, as far as the power thing, I think we're talking about more moderate types of load at faster speeds. So like the bounding, I don't think that you necessarily need a weighted vest in order to maximize some of those plyometrics.
Yeah, sounds right. I don't know much about it. I would just say follow the same 10% rule, maybe, just to avoid injury.
Someone asked, do I really need to stretch before a run? Any recommended stretches?
Boy, they've asked a very difficult question right there, and I'm glad you're here.
Okay. I mean, I think anyone who's like worked with me probably knows I'm not like the biggest fan of stretching. In general, I think that without like talking too much, like there are definitely like people who are drawn to things like yoga a lot of times tend to be hypermobile. There are conditions where people are what we call hypermobile, or essentially like too much laxity in joints. And I would say like I kind of fall a little bit towards that end of the spectrum. Point being is that like I think too much stretching and too aggressively can lead to problems and injuries. And I would say it's not uncommon. Like I fairly frequently will hear someone say that they started having issues like while or because they were doing a lot of yoga. And again, like this is totally dependent on body type. There's certainly people that can do it and I think benefit from it. Regardless, I would say that there is like very solid evidence to show that static stretching before you exercise is really not recommended because it's actually going to decrease the performance of the muscle afterwards. So unless you're like intentionally trying to, restore muscle balance, say to maybe your like running form, and you're trying to deactivate a muscle, or something like that, I don't know. I would say that static stretching before exercise is generally just has been kind of debunked. So what is supported is more doing mobility type of exercises. So where you're actively moving, I mean, even if that's some leg swings or doing some lunges or just some air squats, doing some like side to side lunges, but where you're doing more of a mobility type of thing, but you're continuously moving, you're not doing a static hold.
Yeah, I think that's so interesting. If you're trying to get a 1 rep max or a vertical jump personal best, do not stretch before you do it because you'll decrease your strength and your power significantly by those stretches. I look at it as like if an activity is going to involve certain motions, it's probably a good idea to kind of move through some of those motions in a kind of a controlled way before you do them in a non-controlled, competitive way. But I don't know if that's accurate or not.
What are your thoughts on custom orthotics? Should they be used indefinitely for running?
So my take is that there are some people who absolutely need them and can use them, and there are others who don't. So, I mean, I don't know how else to put it. There are some people who are so hypermobile, so unstable, or have preconditions like we talked about the posterior tibial tendon, who really would benefit from orthotics. I don't think every single person needs an orthotic, but what do you?
Yeah, I would absolutely agree. And that's a perfect example of and I didn't want to dive into posterior tibial tendon because it is so foot involved, and I didn't really want to go down that rabbit hole. But yeah, I would agree that it kind of depends on the individual. The only thing that I would say is that when it comes to running and orthotics, a couple things. Uh, I'm not a huge fan of like the solid, like hard plastic for running. But I do think that something more off the shelf, like the Superfeed or Curex, that has a little bit of flex to it is probably better. And I think it's also like important to note, something that Jay DeSherry, who's a PT and kind of like the running guru, has pointed out is that in the running stride, the most pronation occurs when your heel has already come off the ground. So when you're in that toe off phase. So, well, yes, I think definitely like orthotics to help with an arch support, for example, with someone like with the posterior tibial tendon issue is warranted. That like because your foot is or your heel is going to be off the ground when your most pronated position in the running stride, that like an arch support is really not going to be as beneficial as I think a lot of people might think. So what is important, I'll say like, with preventing maybe some of that overpronation is being really strong through the first ray or the ball of the big toe. And that's where the majority of our balance is when we're running. So that would be, again, something that you would also want to be strengthening and emphasizing.
Could you provide advice related to exercise to prevent ankle sprains when an individual has had a serious sprain in the past? So kind of protective ankle exercises.
That's a good question because the number one predictor of a tendinopathy, of tendon problem, is a previous history of tendon problems. And similarly, the number one predictor of an ankle, the risk factor, if you want to call it that, is a previous ankle sprain. So how do you prevent it? I mean, it's a whole slew of various things.
So I mean, Jessica Galgiani did a couple of great talks this past year, and I think that she did one that kind of focused on ankle stability, especially in the springtime with returning to the trails. So I would just recommend that you go to YouTube and watch that video. But a lot of like balance, single limb activities, and a big thing with ankle sprains is proprioception. So that would be like balancing with your eyes closed, essentially, is something that's recommended. Yeah, that also reminded me too, something I did want to mention as well as the talk last year by Susan Inscore and Jessica Galgiani on bone strength. I would also recommend people maybe go back and revisit, because there I think are a lot of very similar principles as far as like the heavy loads that they discuss in that talk that kind of are very similar between whether you're trying to strengthen tendons or bones.
Great. That is all the time we have tonight for questions. Our team would love to hear your feedback on today's presentation. If you have the time to fill out a quick survey, it will appear right after the webinar has ended. You will receive an email with the recording of the webinar within the next 24 hours. Thank you for joining.